ค่ะเริ่มเลยนะคะ
ค่ะอาจารย์ได้ยินไหมคะ
ได้ยินค่ะ
ค่ะเริ่มเลยนะคะก็Good afternoon everyone I am Padmaswat Khampashir, a first year resident of family medicine. Today I'm going to present interesting case in our patient department. Let's start with the chief complaint. A 53-year-old Thai female presented with rash and an oral ulcer 7 hours prior to admission. For the present illness, 5 days prior to admission, the patient reported feeling an electric shock in the face. She visited a neurological hospital and was diagnosed with peripheral nerve inflammation. The patient was prescribed carbamazepine, which she has been taken for approximately 5 days. 2 days prior to admission, the symptoms had not subsided. So she visited another clinic and was prescribed Dican, which containing ergotamine tartrate 1 milligram and caffeine 100 milligram. She has been taking it for about 2 days. And 7 hours prior to admission, the patient experienced severe nausea and vomiting with 2 episodes of vomiting consisting of food remnants and bile. She also had loose stools 5 to 6 times without presence of any blood or mucus in the stool. The patient developed low-grade fever, a rash on the body, and peeling skin around the mouth. She also had a burning sensation in the vaginal area and groin, some eye pains with discharge, and red eyes as well. There were no accompanying symptoms such as palpitations, chest tightness, or loss of consciousness. For her past history, her underlying disease were are diabetes mellitus, hypertension, and dyslipidemia. Her current medication, she had taken metformin, gibberellin, Losartan, amlodipine, and atorvastatin. She denied food or drug allergy. She denied herbal drug use. And this is her drug timeline. Uh, she taken her current medication, 5 drugs, for a long time, more than 2 months. And she taking new drug which is carbamazepine. She start 5 days prior to admission, and also along with Decan and Yolobin, she start 2 days before admission. And Berocca vitamins, she start only once on the admission date. And please describe the lesion. Could anyone identify this lesion? Could anyone in the fall answer to this question? Could anyone from the fall?
For this patient, she has an like a scaly lips, like a erosion with necrotic mucosa of a lip, and also her eyes also have a discharge, like past discharge or not, and not sure is it inject conjunctiva also.
Okay, thank you, Ekabi. I totally agree with you. Okay, for the physical examination, her vital signs, body temperature, 39 degrees Celsius. She has a fever, and her pulse rate is 110 beat per minute. She also had a tachycardia, and her blood pressure was 122 over 100 millimeter mercury. And her general appearance, she has good consciousness and eye, ear, head, ear, eye, neck, and throat examination. Uh, she has marked injected conjunctiva with purulent mucosal discharge, and also oral ulcer and erosion with necrolytic mucosa on lip. No lymphadenopathy was seen. And her heart, lung, abdomen, and neuro examination was all normal. And genitalia painful genital ulcer and candidiasis was observed. And for examining her skin lesions, seeing the erythematous bubbles at abdomen and moist erythematous plaque at lower abdomen. For the problem list of this patient is a 53-year-old female with an oral mucosal ulcer with conjunctival injection and pulmonary discharge with genital ulcer and rash at the abdomen with fever. Number 2 is history of taking carbamazepine for 5 days, and her underlying disease, diabetes, mellitus, hypertension, and dyslipidemia.
Just one point. That first point, the problem list, it's not she's a 53-year-old woman, it's what is the actual problem? It's an oral mucosal ulcer.
Okay.
It's not she's 53-year-old female.
Okay.
You see, it's not part of the,
Okay.
if I may, just.
Okay. Only oral
You know what I
ulcer.
mean?
Okay, I know. Thank you. Okay. And what is the differential diagnosis in this patient, and what is the further investigation? Could anyone address to this question?
Differential diagnosis, one is Stevens-Johnson syndrome, two is erythema multiforme, three is stress investigation, CBC, urine creatinine, ELI, liver function test.
Am I speaking too quickly?
Ah,
Do you understand?
yes,
If you
thank
take
you.
a breath before you say it, you have enough breath to keep the tone going. But at the moment, it was dying away, and then it becomes almost a whisper. So
Ah,
if everyone's listening to it,
okay, thank you.
okay. Not just you.
Okay, thank you, feedback. So there are several candidates for differential diagnosis. Firstly, the most likely diagnosis is Stevens-Johnson syndrome because the patient had prodromal symptoms before the rash began, and she also had more than 2 mucosal involvement, which are oral mucosa, ocular, and genital mucosa. Another supportive reason is she has history of taking high-risk drug use, which is carbamazepine within 4 to 28 days. Uh, and secondly, the differential diagnosis might be erythema multiforme because the patient has a erythematous plaque and localized eruption of skin and mucus ulcer. She has an oral ulcer too, but the less likely reason because she had no typical target lesion, and this disease rarely associated with drug and rare involvement of the tongue. And thirdly, number 3 diagnosis is staphylococcal scalded skin syndrome because she has the problem of sore throat and purulent conjunctivitis, but this disease has no membrane involvement, so it's the less likely diagnosis. And the last one is stress. We can think of this disease because the patient has fever and have rash and also mucosal involvement. But this disease usually have the onset of eruption 2 to 6 weeks after taking drug and no lymph node enlargement.
Sorry, can I ask a question?
Uh,
I just want to test you
Okay,
to see
okay.
if you can say it, because it's difficult probably.
is there drug reaction?
Drug
drug reaction with eosinophilia and systemic symptoms. Yes, it's wrong. My God.
Okay, thank you. Okay, so for the investigation, the doctor at OPD sent CBC, urine creatinine, electrolyte, and liver function tests, which are the basic laboratory to invest the complication of this disease and to differentiate the diagnosis of the disease. So the laboratory investigation shown hemoglobin 11 and hematocrit 73, which is a mild anemia, monochromic, microcytic, and hypochromic anemia. Okay, and the platelet and white blood cell count is normal, and also eosinophilia is normal. And BUN creatinine is a little bit high, slightly high from her baseline. And she has a mild hyponatremia, and she had hypomagnesemia. The liver function test was mild transaminitis, and her high sense C reactive proteins was high. For the urine analysis, her urine specific gravity is high 1.028, and also for the proteinuria, glucosuria, ketonuria, and hematuria as well. And for the stool examination is all normal. So the provision diagnosis is Stevens-Johnson syndrome, and the management at OPD, the patient admit to medical ward, and the doctor at OPD consult pharmacist and consult dermatologist for rule out Stevens-Johnson syndrome, and consult ophthalmologist for superimposed bacterial infection, and also give paracetamol syrup for supportive treatment and IV hydration as well. And for the dermatology note, she know the problem list. First one is suspected early Stevens-Johnson syndrome, and she suggests to supportive treatment and IV hydration, Vaseline ointment at lip, Silocaine viscous before meal, and mouthwash with normal saline, and follow up the metabolic laboratory. If laboratory worsening or clinical not improved, pan systemic steroid and septic workup and empirical IV antibiotic as well. And number two is cutaneous candidiasis. She scraping the skin and send the KOH. For the ophthalmologist note, the eye examination of this patient, I will speak about the only positive findings, decreased visual acuity for both eye and seeing the mucus discharge, and mild injected conjunctiva, both eyes, and minimal minimal punctate epithelial erosion both eye. So he impairs diagnosis in the patient is acute Stevens-Johnson syndrome with ocular involvement. So the management of the ophthalmologist is advised visual prognosis and natural history of the disease, and aggressive cheer every 2 hours, and prophylactic topical antibiotics on the eyes, and steroid, and repeat visual acuity at IOPD. Okay, for the pocket notes of this patient, the patient admitted to medical ward for 15 days. The problem list, first one is early Stevens-Johnson syndrome with ocular involvement suspected from carbamazepine allergy, and the laboratory of gene HLA-B star 1502 is positive. With this gene is the highly associated with carbamazepine-induced Stevens-Johnson syndrome. And the doctor Edward start steroids with either dexamethasone, and supportive treatment was given include IV hydration, adequate pain control, and empirical antibiotic was given too. After the management, the clinical improved. Secondly, she has the first diagnosis of HIV infection. So the doctor at ward worked up the opportunistic infection and also breaking bad news to patient.
When you, sorry, they. Status or clinical condition or
Clinical condition.
clinical condition?
Okay,
Improved. It's
improved.
always- You're not the only one. Many
Okay.
people- It's a tie thing.
Okay, thank you. Okay, and the third problem is TB colitis. During admission, the patient still had diarrhea for 3 days. So the doctor at the ward sent the laboratory investigation, the stool acid fast stained for examining the TB infection. So the stool acid fast stain 1 pass for 2 days is positive. So the doctor at the ward also consult the ID department, infection department, to start the anti-TB drug and vaccine prophylaxis. After treatment, the patient condition is improved. She had no diarrhea and no fever. Yes, so let's start. So let's begin with the second part topic. The Stevens-Johnson syndrome and toxic epidermal necrolysis are acute life-threatening condition, mucocutaneous reactions characterized by extensive necrosis and detachment of the epidermis and mucosal epithelium. And because Stevens-Johnson syndrome and toxic epidermal necrolysis share the same clinical patterns, histopathologic findings, etiology, risk factors, and mechanisms. So they are classified based on the percentage of skin detachment related to the body surface area, which Stevens-Johnson syndromes typically involve less than 10% of the body surface area, while in toxic epidermal necrolysis involve more than 30%, and which the value in between being considered an overlap of the two conditions. The term epidermal necrolysis has been used to refer collectively to Stevens-Johnson syndrome, the overlap, and toxic epidermal necrolysis. For the epidemiology, Stevens-Johnson syndrome and TEN is a rare condition. The estimated incidence across the disease spectrum is 5 to 6 cases per million per year. Stevens-Johnson syndrome and TEN is more common in female, with a female to male ratio of approximately 2 to 1. The risk factor of these diseases are humans, immunodeficiency virus. The studies have found that patients with HIV infection had a 12-fold increased risk of SJS and TEN. This heightened risk is likely to multiple factors, including the use of high-risk medication for treatment of HIV and opportunistic infection, as well as immune dysregulation associated with HIV. And the next one is connective tissue disease. Patients with connective tissue disease have a twofold increased risk of SJS or TEN compared with the patient without. However, because acute form of cutaneous lupus erythematosus may mimic TEN or TEN-like lupus erythematosus, the risk may be overestimated. And number 3, malignancy is the most Common triggers were trimethoprim, sulfamethoxazole, phenytoin, and idiopathic causes. Other risk factor was older adults and Black and Asian patients and the increased drug dose and impaired renal function. For the mortality, the overall mortality rate is 23%, varying from 12 to 49% across the severity spectrum. And for the etiology, the most common cause of Stevens-Johnson syndrome is high-risk medication. Okay, I will show this picture. The strongly associated is the allopurinol, lamotrigine, sulfamethoxazole, carbamazepine, phenytoin, nevirapine, which is an anti-HIV drug, sulfasalazine, and other sulfonamides, and also the oxycam NSAIDs, such as piloxicam and phenobarbital, which is the anti-seizure drug, and etolisib. For the associated and suspected associated or the lower risk that is shown in this picture. You can review after. Okay, and other thing is timing. Usually, the hostative medication is typically start between 1 week to 1 month, occasionally up to 2 months prior to the onset of symptoms. Another cause is the infection, which usually caused by Mycoplasma pneumoniae and viral pathogens. For the other cause, there are rare and controversial reports of HS or 10 attributed to chemical exposure, complementary or traditionally medication, vaccination, and food. Okay, and for the pathogenesis of this disease, when the drug or infectious antigen in the skin tissue there's stimulate the cytotoxic T cells or natural killer T cells or NK cell as well, and they stimulate to granulosin to release and lead to the keratinocyte death. Apoptosis of keratinocytes is make the epidermal separation from the dermis, and it's shown the characteristic skin detachment of SGS and chin. And dying cell and necrosis make the increase of antigen load, so it triggers T cell to continue the inflammatory response and develop a fluid-filled blister. So you will see in the blister. And for the clinical finding, the epidermal necrolysis clinically most often begins with unspecific prodromal symptoms such as sore throat, runny nose, cough, headache, fever, and malaise, preceding the mucocutaneous lesions by 1 to 3 days. They are followed by the appearance of erythematous macule and cutaneous lesion and also mucous membrane involvement. And after that, patient may have their systemic involvement and complications as below.
I think I heard you say,
Uh,
it should be non-specific.
okay, non-specific.
Non-specific.
Okay, thank you. Non-specific. Okay, so for the cutaneous lesion, the eruption is initially symmetrically distributed across the face, the upper tongue, and the proximal part of limbs. The distal portions of the arms as well as the legs are relatively spare, but the eruption can rapidly extend to the rest of the body within a few days and even in as little as a few hours. The initial skin lesions are characterized by erythematous dusky red or irregular shaped purplish macules, which progressively coalesce. A typical target lesion with dark center are often observed, which, as you can see in the picture, and confluence of necrotic lesions lead to extensive and diffuse erythema. Okay, and the Nagelski size or the dislodgement of the epidermis by lateral pressure. If you hate the pressure lateral of the lesion, it will peel. So it's the positive on erythematous zone. And the lesion evolved to flexus blister with spread with pressure and break easily in this picture. And the necrotic epidermis is easily detached as pressure point or frictional trauma, revealing large areas of exposed lead, sometimes losing dermis, as you can see in this picture, or the light. And the mucosal membrane involvement, usually nearly on at least two sides. For the oral mucosa, it can be erosion, blister, and hemorrhagic cellulitis, like in our patient. And it can be coated by gauge white pseudomembrane and hemorrhagic hush on the lip as well. And nasopharyngeal, for the nasopharyngeal, it can be erosion, blister. Patient can have epistaxis and epiglottitis. For the genital, his patient can present by dyspareunia, vaginal dryness, and genital adhesion. And for the ocular, the conjunctival lesion can also fall. The pain or photophobia, lacrimation, redness, and discharge. Epithelial defect and corneal oscillation, anterior uveitis, and purulent conjunctivitis also can fall in the Stevens-Johnson syndrome patient. Okay, and for the systemic involvement, there are many systemic involvement. For the renal involvement, the patient can have the acute kidney injury, which is common, and also proteinuria. And in the worst case, they have to the renal replacement therapy. For the pulmonary involvement, a specific lung injury may be found, and pneumonia, pulmonary edema, and atelectasis. For the gastrointestinal involvement, the patient can have abdominal pain, diarrhea, hematemesis, mirena, rectal bleeding, or iris, and also can find the SJS-10 related lesion involving the esophagus. Okay, and the liver injury is the independent risk factor for dark-induced liver injury include underlying liver disease, hypolipidemia, and diabetes. And hematologic abnormality can find the laboratory showing the anemia, leukopenia, and thrombocytopenia. And in the worst case, can find the DIC or disseminated intravascular coagulation. And bacterial and sepsis is the common complication and associated with a 3 to 4-fold increased mortality risk, with sepsis and septic shock are the main causes of death. A risk factor for bacteremia is age more than 40, white blood cell more than 10,000, and body surface area involvement more than 10%, and hemoglobin less than 10, and underlying disease of cardiovascular disease. And most common pathogen is caused by Staphylococcus aureus and Pseudomonas aeruginosa and other gram-negative bacteria. As for the differential diagnosis of this disease, were so many diseases. For example, erythema multiforme, Staphylococcus scalded skin syndrome, generalized fixed duct eruption. Okay, as this table is showing the differential diagnosis between SJS and 10 versus erythema multiforme. For the characteristic lesion of Stevens-Johnson syndrome and TENS, there are atypical target lesion. You will see in the macro with central curling and two poorly demarcated components. While erythema multiforme, you will see in a typical target lesion. They have the papules with a dark center and three well-modified and concentric components as in this picture. This is a typical target lesion, and this is non-atypical target lesion. And for the distribution, Stevens-Johnson syndrome typically begins on the face and tongue with centrifugal space, opposite to erythema multiforme, which they start at the face and axial skin, which are the distal and layer involvement of trunk. And the trigger of Stevens-Johnson syndrome usually is a duct. Is the most common cause, but in the erythema multiforme, infection is mostly common cause, and is most commonly caused by the herpes simplex virus and mucosa involvement is very common in Stevens-Johnson syndrome. And most cases have involvement of more than two mucosal surface, as I mentioned above. And erythema multiforme is a rare mucosal involvement. And if they have a mucosa involvement, they're typically only one. And for the recurrence of Stevens-Johnson syndrome, it's rarely seen because we usually remove and avoid the causative duct. But the erythema duct multiforme frequently seen because the patient can be infected, can have a recurrent infected. And for the histopathology, it's the same.
Infection.
Infection, okay. Okay, for the early stage, the board disease will see in the basal layer liquefaction with vacuolar interface chain and scatter necrotic keratinocytes. Okay.
Nongmuk, excuse me for interruption. Could you back to the slide, differentiate Stevens-Johnson and EM? Next slide. Okay. And on for the practical, could you differentiate Stevens-Johnson or TEN from EM on the physical examination?
Under physical examination, maybe distinguished by seeing the lash, the erythema multiforme will be the or mostly being the typical target lesion, but Stevens-Johnson syndrome is a typical target lesion. But sometimes, in some cases, it may be similar.
Mhm. Here is one thing is about the Nikolsky sign that you just already discussed before. In the Stevens-Johnson or TEN, Nikolsky sign will be positive, right? But in the EM, it's opposite.
Okay, thank you. Okay, and next, the clinical course and prognosis. The epidermal detachment occurs for 5 to 7 days. Then patient enter a puddle phase, which corresponds to progressive reepithelialization. This can take a few days to a few weeks, depending on the severity of the disease and the prior general condition of the patient. During this period, life-threatening complications such as sepsis or systemic organ failure may occur. Okay. Okay, and this picture shown the progression of patient And the day 3 of admission, the lash began. At the day 8, the epithelial is the detachment. And after 3 months, is improved. And 3 years doesn't see any lash. Okay, under clinical cause and prognosis, we use the SCORE-10. It's a prognosis scoring system for patients with epidermal necrolysis. It includes the prognosis factor of age more than 40 years. It gives 1 point. Heart rate more than 120 beats per minute, 1 point. And cancer or hematologic malignancy, 1 point. And body surface area involved more than 10%. And also the serum urea level more than 10, and serum bicarbonate level more than 20, and serum glucose level more than 14. And is you can calculate and prognosis the mortality rate. And for the treatment of this disease, epidermal necrolysis, firstly, you should early recognition and immediately withdrawal of everything that, in this case, we avoid the carbamazepine, stop the carbamazepine. And secondly, the supportive treatment. Usually in this disease have the epidermal detachment, so the patient may have the fluid loss because from the erosion, and which patient result in hypovolemia and electrolyte imbalance. So you have the fluid replacement must be start as soon as possible and adjust daily. And peripheral venous line are preferred when possible because the site of insertion of central line are often involved in the detachment of epidermal and prone to infection. And early nutrition support is preferentially provided by nasogastric tube to promote healing and to decrease the risk of bacterial translocation from the gastrointestinal tract. And to reduce the risk of infection, aseptic and careful handling is required. And skin, blood, and urine specimens should be cultured for bacteria and fungi at a frequent interval. The prophylactics antibiotics are not indicated. Patients should receive antibiotics when clinical infection is suspected. And prophylactic anticoagulation should be provided during hospitalization. Okay. And the extensive debridement was not recommended. And number 4, early ophthalmologic evaluation and care would be given. The use of preservative-free emollient and antiseptic eye drop and vitamin A. And number 5, antifungal and antiseptic mouth rinse should be given to every patient. To-
Quick question. The reason why it's not recommended skin debridement is it's just like having a burn when you lose the skin and it's the fluid leaves. Is that the reason?
Oh, the reason is because the superficial necrosis is not an obstacle to repiturialization and might even accelerate the proliferation of stem cell due to inflammatory. Yeah. Yeah. And for the specific treatment in acute state, it may be a systemic steroid, but the use of systemic steroid is controversy. And if suggest to use such as the medium dose for short periods, may be beneficial. And cyclosporin A is also recommended for an anti-TNF monoclonal antibodies may be efficient.
Efficient? or
May
effective?
be effective.
Effective.
Effect- Okay. Okay.
Okay.
Okay, thank you. Okay, this is a definite reference of the topic review. And thanks you everyone for your attention. And do you have any question?
Do you have a case like this before? Have you? Okay. Okay, thank you. Okay. Okay.
Okay, for me, Dr. Silima, I'm a rheumatologist. Okay, for the lesions of the thin line lesions, another diagnosis is maybe thin like SLE, but it's just a bias from my perspective. Okay, but here the differential diagnosis of thin line SLE maybe have the another side of the SLE such as proteinuria, rash, or arthritis. So and no any history about medication. So you need to think about SLE a little bit, okay? But for overall for this presentation, I think it's awesome. Okay, thank you.
Okay, thank you, teacher Silima.
ก็ today thank you น้องมุกนะคะที่for review the interesting case and review the topic. I think the important thing is early recognition, early detection, and early removal the causative agent because it will decrease the rate of mortality. Okay. Teacher Maurice, do you have any comment? Okay.
Sorry, when you speak about stools, you always talk in the plural. You don't say stool. It's always stools, and including in the thing. More time to voice. You need, especially the technical words. You need to allow the time to voice them. And you have to be careful with the tenses. If you're discussing what you're seeing on the page, as opposed to the background case, then it's okay to speak in the present tense because you're saying about what you're describing what you're saying. But if you're actually referring to the patient's condition or the history, then you should generally speak, unless it's right now, you should be speaking in the past. If you're giving your opinion on something, then it's a concept. It's I would, or it would be dangerous to debride, this sort of thing. It would be. It's not an actual case. It's only thinking about it. Marked. You don't say marked. You say it's normally it's one of these funny words. Marked. Marked. There was a marked. A marked indication or something that
Yes. And before you speak, oh, I mentioned this, before you speak, take a breath, because you have control over the voice a lot better, and it doesn't die out. What else? Usual. Yes. Usual have. Usually have, or usually, that's a generalization. It's not, or usually had. Yes. And yeah, there are a few other, I'll have to go through them, but show and showed. Shows or showed. Was admit. Was admit. No. Past tense was admitted. Not admitted, it's admitted. It's one of these voicing things. High intonation. You know what I mean? When you computer, it's computer, it dies away. Sometimes when you speak in English, you rise and then you to introduce what you're going to say, and then you fall away. It's that way. It's not ending up in the air. It's beginning with maybe a clause or something, first part, and then you go into the main subject where you die away. What else? An interesting word, including. If you say a sentence, and this is writing as well, if you say a sentence and you're going to list items, if the sentence makes sense without your going on to list them, then you put a comma in there, because because it's rather like saying we must have these, full stop, including. If you're going to include, then you put an including, comma, comma, comma. You don't need a comma before in that case, because it's this part here is essential to the meaning of what you're trying to say. So it has to be in one. But if you could drop this off, then you don't need to have it in there. It's you just can have a comma in there. Yes, it's a clause. There's additional information, effectively. What is it? Consulted. Send or sent. Send is present, sent is past, and consulted is the way you say it. You not consulted, and certainly not consult. We consult the patient unless it's present. Causes. You say causes. Causes. It's not aspirated. It's as if it's K-O-R. How would you say K-O-R? Very sharp. Core. 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 Z. Core. Z. Core. Not causes. You see the difference? Yes. Technical terms. You need to spend, not just you, but one or man, one needs to spend time on making, if you're going to speak to people. What else? Non-specific as opposed to unspecific. What else? Oh, yeah, there was another one here. Many systemic involvement. No. Many, it's systemic involvement is not countable. So what you actually should have said was, as an example, significant or widespread systemic involvement. That's better, yes? That's a bit of time. And recurrent infection. Or recurrent, recurrent infection. It means it's coming back, yes? Recurrent. Sit now.
you teacher Morris โอเคค่ะ
You won't remember this. You have to hear it. And if you want to listen to yourselves just a little, then it's really good. You can work